Hello, and welcome to the 2025 Engagement Lounge webinar series presented by the Association of Neurovascular Clinicians. My name is Jody Walter, and I will be moderating this session, Clinical Localization of Stroke. ANVC is dedicated to the creation of seamless neurovascular care services led by evidence-empowered clinicians that fully support the holistic needs of patients and their families, because stroke patients deserve nothing less. For more information about ANVC, please go to www.anvc.org and become a member. We do have a few housekeeping items before we begin. This session will be recorded and made available in the members-only section of our ANVC website. However, only viewers who attend this live session in its entirety will receive one continuing education hour. Viewers will receive an evaluation from Arizona State University. After completing and submitting the evaluation, participating viewers will receive a continuing education certificate. But again, you must attend the entire live session to be eligible to receive credit. If you are joining the webinar today under a phone number or nickname, please enter your name in the chat or send an email to info@anvc.org in order to ensure you receive the evaluation for CE credit. Please feel free to enter any comments or questions into the chat throughout this presentation, and at the very end, we will review questions with our guest speaker. Now, I'm proud to introduce our guest speaker for this webinar, Alicia Richardson. Alicia is a stroke system director for the Penn State Health System in central Pennsylvania. She obtained her BSN from Plattsburgh State University in 2008 and her master's degree as a clinical nurse specialist from St. John Fisher College in 2012. In 2018, Alicia completed a postmaster's advanced practice neurovascular fellowship program. She has 17 years of neuroscience nursing experience and is board certified as an advanced neurovascular practitioner. Alicia is currently the president for the Association of Neurovascular Clinicians and recently graduated from the World Stroke Organization's Future Stroke Leaders Program. Alicia has held numerous stroke leadership positions and has special interest in stroke systems of care, and particularly the hyperacute phase of stroke.
Are we all set?
I think so.
All right.
We're excited to hear you today.
Thank you. So thank you for having me give this talk. I think that this is a challenging talk to give in less than an hour, and many of you are very familiar with this topic as well. I was asked to kind of try to bring a more basic level of clinical localization of stroke to this webinar, and so I apologize in advance if those of you who are on this call are a little bit more advanced in the clinical localization realm of things, but hope you have some takeaways as well. So we'll go ahead and get started. I have no disclosures. So first, why or what is clinical localization? Clinical localization is really a valuable tool for all of us. It's helping us to identify a specific area of vascular territory of the brain that's been affected by stroke based off of what we see for the clinical signs and the neurological symptoms. So it's taking those neurologic deficits with what we already know about the anatomical structures and our cerebral blood flow territories, and then deciding where we think that specific occlusion might be for that patient, or a hemorrhage as well, right? So either type of stroke, localization is localization, and it doesn't, it's not specific to any specific type of stroke. So we really are going to be able to differentiate anterior versus posterior, cortical versus subcortical, left versus right hemisphere, and kind of be able to pinpoint exactly where the patient might be having their stroke. And when I teach clinical localization and when I teach the NIH stroke scale to bedside nurses, I always tell them that this is kind of like a little bit of our superpower, right? It's really important for us to be able to do this skill, have this skill as neurovascular clinicians. It's really our way to decide what's going to happen with this patient, especially in the hyperacute emergency management phase, even before imaging is available to us. Even before we've worked up the patient completely, we can really hone in on those skills, use those skills to elevate our practice, make sure that, you know, we're determining the level of injury based off of where we see the patient's symptoms. And so it is kind of like your little superpower in your toolkit of knowledge And I think that it's really fun to see these skills grow as we become into more stroke specific roles. We might be kind of, weak in this topic because it is a complex piece of knowledge. And so it does take us some time, and we build on it and build on it and learn more and more about clinical localization as we become more intimate with the field. I think it's always really fun to see like med students and new residents that join our team who, we see this patient rolling in the stroke alert process. We do the NIH stroke scale on them. We start as immediately identifying where we think we localize that particular stroke to, and call out where we think the stroke is. And it's always a really fun thing to see like the med students and the residents like eyes wide, like, how did you know that? They're so like amazed at like, how did you know that that's where the stroke was going to be? And it's like, you'll get there. You'll have to build these skills. You have to develop them, and it takes time and practice. So it's always good to do that in your stroke alert process, right? Think about what the symptoms are presenting with, and then see if you can identify where that stroke is before you even have imaging to help support where the location is. Clinical localization also really helps with differentiating non-vascular mimics for our patients as well, because if we know the anatomy, we know what the vasculature looks like, then symptoms that also don't make sense can help us to say, this probably isn't a stroke. This is probably more this or that, because we know that doesn't follow a typical stroke distribution pattern that we would see in that vascular territory. I think it's really hard also to teach the brain and the anatomy of the brain when we don't have it in front of us. We can't hold it and flip it around. This is going to sort of try to do justice of that, but to remember that this is a 3D object. We see tons of images of brain on a flat, 2D image. But remembering too that this vasculature that we're talking about is really tucked all inside of here. And we're going to see a picture here in just a minute of that kind of tissue sort of taken away a little bit, but you can see the circle of Willis and all of the vascular territory lies all nooked inside of these deep in the brain. And really, the circle of Willis, if you've seen a human brain before and looked at that vasculature, the circle of Willis is, I don't know if I'm in the video, but more like this shaped, right, in the brain, rather than flat like we see in pictures. So it's more curved inside of our head, tucked all in here. So here's that typical picture that we all, see. And I always say this is my favorite picture in the slide deck, and other people, non-neuro or non-stroke people, their least favorite, right? Because this is a very like, oh my gosh, I don't know if I know all these vessels. That takes a lot of memorization when you're first learning. So to orient you, right, this is the brain tipped up and looking at the bottom side of the brain. We've got the front of the brain here, the back of the brain here. Our eyes would be right here. And so then brainstem is all here. Cerebellum is back here. And we've got a line in the middle here showing us the anterior division versus the posterior circulation. So everything above the line is considered anterior circulation, and everything below it is considered posterior circulation. So if we follow up our neck, right, we've got our common carotid arteries, and then at about the level of the jaws where they become the internal carotid arteries, so right here, our right and our left, then those branch off to then become our middle cerebral artery, our MCA, the most common location for a stroke. And that is because off of the aortic arch, if we imagine that vasculature, it's a pretty straight line, a straight shot up our carotid artery, up into our internal carotid artery, and then right into our middle cerebral artery. So there's not a lot of sharp turns and twists that a traveling clot would need to take. It's just going to go the path of least resistance and go straight into our middle cerebral artery. I have pictures coming up to, of course, show all of the different vascular territories that each of these vessels make up. We're going to talk about the most common occlusions in this webinar today. But I think everyone probably remembers that the middle cerebral artery is the largest territory, about makes up at least a fist. If you put your hand up by your head or like do this, this is how big the vascular territory is for your middle cerebral artery. So just a huge, huge territory. Then off the top of, so here's our circle of Willis, and off the top of the circle of Willis, we have our anterior communicating artery and our ACAs, our anterior cerebral arteries. Those two are going to go up off of the anterior communicating artery and wrap basically in front of our eyes and up to the top of our head. So in this strip-like pattern. Then in the back, in our posterior circulation, we've got vertebral arteries going up the back of our neck. As they get into the brainstem, the level of the brainstem, they join together to become the basilar artery, the deadliest location to have a stroke. Then off the top of the basilar artery, we have a left and a right PCA, a posterior cerebral artery, and those help supply the occipital lobe. And we'll talk about that in some upcoming pictures. And then basically we've got three vessels off of the different parts of the basilar artery here and the vertebral arteries. We've got the superior cerebellar artery that wraps around and supplies the top portion of the cerebellum. Then we've got the anterior inferior cerebellar artery, or AICA. That one also wraps around to supply a portion of the cerebellum. And then the posterior inferior cerebellar artery, or PICA. And we'll go through all of these in a little bit more in depth, but that's kind of the higher level overview of the different vessels. I think an important thing to remember too is that only about 50% of the population has a complete circle of Willis. And so you will see some variance in this in different patients. The most common variants that you'll see are a missing A1 segment, so the first segment of an ACA. So basically this part of the brain is being supplied by your anterior communicating artery and going up the other side. And then your other variant that's very common is a PCA. So a P1 segment, the first segment of your PCA missing. And then the third most common is a PCOM-A that's missing. All right, so another kind of refresher slide of the different lobes and what they do. And this is also another important part of learning localization, is understanding not only the vascular territories and what lobes they supply, but what those lobes do, and so that you can understand what deficits you might be seeing. So if we look at, this is the entire cerebrum, and the cerebrum really makes up 80% of our brain's weight. The outer layer is our gray matter, our cortex, and about 2/3 of our cortex is actually bundled and wrapped within itself with all those convolutions and of the gyri, so folded kind of in on itself. And then our white matter is more deep in the brain, and I'll have some better pictures of this coming up where you can see the difference between the gray matter and the white matter. So when we look at the different lobes here, we can see the first one in this light blue is our frontal lobe. So we've got voluntary movement, such as lifting your arm, because we have the motor strip back here in the back of the frontal lobe. We have an inability to maybe to focus your attention. You have some emotional, social, or sexual control issues. If you impair your frontal lobe, I always refer to this as the mother lobe. It's the lobe that's keeping you appropriate, having a filter, not saying inappropriate things. So sometimes when we have strokes that happen that affect our frontal lobe, we have patients who may be having behavior issues that they didn't have before, impulsivity type of things, lacking that filter. We also could have some inability to speak because we have Broca's area back here in the frontal lobe as well. So we could see some aphasia. And then we have, of course, decision-making concerns as well because of that frontal lobe being impaired. When we get back to this darker gray color, our parietal lobe, we have awareness of body parts coming from this part of the brain, some academic skills, some naming of objects, some hand-eye coordination come from here as well. And then when we move to the temporal lobe, we've got short-term memory located here, understanding speech. So we've got Wernicke's area about back here. And so we could have some receptive aphasia if we have a stroke there. You have recognizing faces and some behavior components there as well. And then the occipital lobe, for some reason, everybody remembers that the occipital lobe is for vision. So that one is usually committed to memory. Whenever I teach the NIH stroke scale and talk about these, everyone knows what the occipital lobe does. So ability to see and understand what you are seeing. Also reading comes from there. And then we move down to the cerebellum, which is responsible for balance and coordination. Brainstem, we're going to get into a little bit more in depth towards the end of this webinar, but we've got our autonomic responses. So things like breathing, heart rate, blood pressure, digestion, consciousness, like our sleep-wake cycle is located here. We have lots of cranial nerve functions that flow around our brainstem, motor and sensory pathways, and then coordination and balance can come from here as well. So that again is just a kind of an overview of the different lobes, which is probably a refresher for many of you. Then we have what's considered our dominant or non-dominant hemispheres. And I think this picture is you know, you can find tons of these pictures on the internet of like what's considered right brain functions versus left brain functions, and what type of people are considered more left brain or right brain based off of, you know, their creativity and their artistic abilities. And that usually comes from more the right side of the brain versus like the analytical side. Academic side is more considered the left brain functions. But when we think of dominant versus non-dominant, the dominant side is usually the hemisphere that's responsible for language processing. So things like speech, writing, comprehension, naming, reading, and this is typically the left hemisphere for the majority of the population. Then our non-dominant would be the right side, the opposite hemisphere, and it's responsible for spatial awareness, attention, and then all of our nonverbal skills. When we think about our cortex and our subcortex, the cortex is really that cortical piece that I mentioned earlier that's really looking at the outer layer of the brain's responsibilities for those higher level functions. So thinking, language, sensation, motor control, whereas the subcortex or the subcortical is the deeper brain structures. So like in this picture, we've got the basal ganglia, the thalamus, the internal capsule, the corona radiata. All of those deep brain structures are considered subcortical, whereas all of these things are considered cortical. So on more on the outside, the gray matter. And this becomes really relevant when you think about like looking at large vessel occlusion symptoms, right? When we think of a large artery that might be occluded, we're really wanting to focus on those cortical symptoms. So a good large vessel occlusion tool might have all of those cortical findings that you would see because you would expect a large artery to be impacting those. So here's kind of a nice summary slide to talk about large arteries versus small perforating arteries. And I really like this picture because here's your MCA, for example. So you've got your MCA, and then this is considered, you know, your large artery. So big, giant artery. Then you've got these little tiny vessels that come off of your large arteries, and you have them everywhere off of all large arteries in your brain. This one off of your MCA, these are called ventriculostriate perforating vessels. And so a small artery stroke, like a lacunar stroke, would be affecting some of these vessels here. Whereas a large left MCA stroke, right, would be affecting this big, large vessel. So from a large artery stroke, you would expect these cortical findings. So you would expect aphasia if it's in your dominant hemisphere. That's very common. You would expect neglect if it's in your non-dominant hemisphere. So the majority of people, that's on their right side. So like, for example, a right MCA stroke. You would expect some visual field deficits. And we're actually going to go into the eyes in a little bit more detail later in this presentation, because I think the eyes are one of the most difficult thing for people to understand. And so hopefully I can help with that. And then you can have pure motor and sensory symptoms, although those are somewhat rare to have just a pure motor and sensory symptom. Usually you have motor sensory with those other deficits, vision, aphasia, or neglect. And then basically this right-hand side, subcortical clinical features, is the opposite, right? You're rarely going to see aphasia. You're rarely going to see neglect if it's in the non-dominant hemisphere. You're less commonly going to see visual field deficits, and you will see pure motor sensory symptoms. That's very common to see that in small artery strokes or subcortical. All right, so we're going to focus just on that anterior circulation when we talk about the different vessels that could be occluded or have a lesion there. So we're just going to focus on the things that are above that line. So when we look at that ACA, that anterior cerebral artery, that's the one that goes up and wraps up to the top of the head, goes behind the eyes and wraps up. So it's in this strip-like pattern in that blue. Because it goes up and it hits the very top of the motor and the sensory strip. Remember, I don't have a picture of this, but you remember the motor homunculus and the sensory homunculus, how they have that little man that wraps over the top of the motor and the sensory strip to show you what body parts give you, ability to move or feel. Leg is at the very top. So you have leg, and then you have arm, and then you have face. And so because the ACA goes up and it wraps up to the top, it could hit the leg, and the leg weakness could be more dense than the arm or the face. And so contralateral leg weakness, so opposite side leg weakness, could be more dense. Same thing, you could have more sensory loss on that other leg. You could also have abulia, which is lack of initiation or motivation. You could also have impaired orientation or any of those things that we talked about in the beginning where we're talking about that frontal lobe being impacted, right? Because this is supplying a large portion of the frontal lobe. And also just remember that a primary ACA occlusion is relatively rare. So typically we see the MCA being more impacted in the anterior circulation, or if we have an ICA occlusion, we might see ACA and MCA symptoms, but primary ACA occlusions are relatively rare. All right, so then when we move to the middle cerebral artery stroke, we have differentiation between the right and the left on here for you. And it's this huge territory, right, that I just colored in orange, also hits the motor and sensory strip and hits arm and face a little bit more dense than the ACA did. So we have a right MCA stroke would give us, of course, left hemiparesis. It could give us a right gaze deviation. We could have neglect on the left side of our body. We could have a left facial droop. We could have a left homonymous hemianopia as well. And again, we're going to go into all the eye things in a little bit. With both right and left, you can see dysarthria, and you can see also dysphagia as well. And then the left side is essentially the opposite symptoms, but with aphasia, and like you'd see aphasia on the left more than you'd see on the right side, you'd see more neglect. And then I just threw this in just to remember that the internal carotid artery is going to give us, let me just advance these, is going to give us all of these symptoms, right? Because this is the vessel that leads up to the middle cerebral artery and the ACA. And so if we have an occlusion here, we can see really significant symptoms, all the ones I just mentioned. All right, now if we focus on the posterior circulation, just the end here, or the back, we're going to focus just on the PCAs and look at those. So this is that vascular territory that I just colored in purple. We can see contralateral homonymous hemianopia. So a field cut and a vision loss. And again, we're going to talk about that in a little bit more in depth coming up here. You can also see cortical blindness, but that is very, very rare. So that is from an occlusion that goes up the basilar artery and sits right at the top of the basilar artery and blocks off both of those PCAs. Or you could get it from consecutive clots that go both, like a clot that breaks and goes into two pieces into the PCAs. But again, very, very rare, hardly ever see cortical blindness. Most often you're going to see either a quadrant that's missing or a whole half of vision that's missing. And again, we'll show that a little bit better in some upcoming pictures. Then you could also see contralateral hemisensory loss because the thalamus is located right here. So thalamus leading to the PCAs in the occipital lobe. So we can see some thalamus functions being impaired as well with PCA strokes. So we can see some fluctuating level of consciousness issues. We could even see some aphasia if it's from the left side of the thalamus. We could see memory problems as well if it's from the medial temporal lobe and the thalamus. All right, then moving to our cerebellum, this structure down here. And we can see this nice graph or this picture shows us all of those arteries that I mentioned earlier. So the superior cerebellar artery makes up for the majority of the cerebellum. So a big, large portion is supplied by that superior cerebellar artery. And then we have the purple, the AICA, the anterior inferior cerebellar artery, and the PICA, the posterior inferior cerebellar artery, listed there or shown there in red. So when we have a cerebellar artery that's impacted, we can see same-sided dysfunction, so alterations in either their equilibrium or their coordination, so some ataxia, inability to really coordinate that motor function. It also commonly occurs with brainstem strokes. So presentation can usually involve motor weakness, sensory loss, alterations in consciousness, and some cranial nerve palsies can be seen as well. All right, then if we move to the brainstem, so we've of course got our regulation of life functions, level of consciousness is coming from here. Again, our cardiac, our respiratory, some vasomotor reactive components, vomiting, sneezing, motor and sensory pathways are flowing through there. We've got lots of cranial nerve functions, and we've got our reticular activating system or our sleep-wake cycle coming from brainstem as well. And here's the different structures of the brainstem. So we've got midbrain here in the red, then we've got pons, and we've got medulla. And you can see how the vessels flow through there. Here's like a closer up view of the basilar artery. So the basilar artery tends to involve cranial nerves and long tracts. So you can see some crossed sensory symptoms and crossed motor symptoms. So what that might look like is a right arm that's weak and a left leg that's weak. So very crossed signs, because depending on where the level is that the stroke is in the brain, if it's right at the level of the medulla junction, you can get some of those crossed or mixed symptoms happening right at the level of the medulla. You can also have diplopia, you could have nystagmus, you could have a lower motor neuron facial palsy, you could have hearing loss, although that's very rare, dysarthria or dysphagia, so those bulbar symptoms coming from brainstem, and then vertigo and lateralized ataxia. The list for basilar artery, the symptoms there, I'm sure you all are familiar, they're extensive. This is not an all-encompassing list. There are far more symptoms than this. We're going to go into each structure of the brainstem just a little bit, just to kind of talk about what you could see in the different components of the brainstem. I like to think of the brainstem in these kind of buckets with our cranial nerves as well. So we've got midbrain, has cranial nerves 3 and 4. Pons has cranial nerves 5 through 8. And then the medulla has cranial nerves 9 through 12. And just here's a visual of that. So we've got cranial nerves 3 and 4. So we've got oculomotor and trochlear. And then we've got 5 through 8, all right here, right at the level of the pons, and then 9 through 12, all down here at the brainstem. So if we focus just on that top structure, the midbrain in the blue, that's supplied by the basilar artery, the PCA, and the superior cerebellar artery as well. So the midbrain really extends from the pons to the thalamus. It helps us with visual reflex centers for head and eye movement. So that's again why all the oculomotor and the trochlear cranial nerves flow through there, right? So eye movements. And so when we have a midbrain stroke, we can see extraocular eye movement dysfunction. We can also see pupillary dilation. We can also see decreased level of consciousness. Decreased level of consciousness is honestly going to be in every single piece of the brainstem, because that's what our brainstem, one of our primary responsibilities of the brainstem is that wakefulness and consciousness. And then we can see motor and sensory dysfunction as well coming from the midbrain. A pontine stroke could be our basilar artery, anterior inferior cerebellar artery, or our superior cerebellar artery. We have the bulge in our brainstem is located beneath the midbrain and above the medulla. So right above here, and below the midbrain. So right in this pink structure is the pons. So again, we've got trigeminal, abducens, and facial cranial nerves that could be impacted. This is where we then now get into breathing and start to get into heart rate as well. This is also where you can get locked-in syndrome. So I'm sure many of you are aware of locked-in syndrome, which is a pontine infarct that can give you quadriparesis, difficulty with respirations, need basically to be usually trached and pegged, and only you're cognitively intact, so you're aware of your surroundings, but you're not able to move anything, so you're essentially locked in to your body. And I would imagine that most of us in this career think that this is the most devastating type of stroke to have in your brainstem is a locked-in syndrome pontine stroke. Then if we move down to the medullary strokes, this is supplied, our medulla is supplied by our vertebral artery, our posterior inferior cerebellar artery, and some of our spinal arteries as well. We've got all of the cranial nerves that are impacted there. We've got now cardiac, vasomotor, and respiratory centers that can be impacted in the medullary space. And we can still see, of course, level of consciousness issues. We can also see cranial nerve and motor sensory dysfunction here. And we can also have lots of syndromes. So I didn't go into all of the different syndromes that you can see in the brainstem. There are many, many, many of them. One of the more common ones that can happen in the medulla is called Wallenberg syndrome, which is wobbly or off balance. If that helps you to remember, Wallenberg is wobbly. You can also see swallowing difficulties, and these are severe swallowing difficulties, like can't manage their own secretions type of swallowing difficulties. You can have hoarseness, you can have nausea and vomiting, and you can also have nystagmus. All right, let's take a pause here and kind of go back to the eyes and kind of go into those a little bit more in depth, because I think this is just a hard concept for people sometimes. So when we think about the middle cerebral artery, and the vascular territory, right, was huge. It was this big. We have frontal eye fields that are located on our left and our right side of our MCA distribution. And so what happens is when our middle cerebral artery becomes involved from a stroke, or, you know, deprived, let's say it was an infarct and it was deprived of oxygen, nutrients, and it started to, you know, that space started to die and it started to impact our frontal eye fields. I kind of describe the frontal eye fields as like this, kind of like a magnet. And I don't know if that's always the right term to use, but this is how I describe it, is like the frontal eye fields are helping to keep our eyes in a smooth pattern, tracking back and forth without having eyes that are all over the place. So they're helping to keep, when we move our head or when we move just our eyes, they keep our eyes together. They're kind of like magnets in the sense that they're kind of pushing together to keep a midline. And so when we lose one side, like let's say I have a right MCA stroke and I lose my frontal eye field on this side. So what's going to happen is this frontal eye field doesn't have anywhere, doesn't have that opposing magnet to keep them centered. So what's going to happen is this frontal eye field on my left side is just going to push my eyes in a forced gaze deviation to my right side, right? I'm going to look towards the side that's having the stroke. And so that's where the gaze deviation or the gaze preference comes from, is it's impacting those frontal eye fields up in the middle cerebral artery space. Okay, so both eyes are towards a direction, right? When we test the NIH stroke scale, that's when we are testing best gaze, right? Follow my finger all the way to the left and all the way to the right. We're looking to see, do they have a gaze deviation? Can they cross midline, or are they deviated just to one side and forced gaze? A little helpful hint is that you'll look towards a stroke and away, usually, if you're seizing. And that's not always 100% accurate, but just to give you a little bit of extra knowledge there, if you didn't know that, it's towards the side that's having a stroke and away for seizure. Then if we think about the eye things that we can see down here, this very different eye dysfunction down here. So this eye movement is more of a gaze palsy when we're affecting our brainstem. So that's usually one eye that's tipping out or down, or just not following that typical pattern, right, of when we have somebody go left to right. So very different than the frontal eye fields being impacted. This is usually two eyes being impacted. Both eyes are looking in one direction, whereas a brainstem or a gaze palsy is usually just one eye doing funny things. Going down and out is usually what you'll see the most common. This is also one of my favorite pictures that I have that I found on the internet that is just, I think, a really good description of what kind of ocular eye movements you can see. So this is somebody who is normal right here, looking left, or I'm sorry, looking right, looking straight, and looking left. So you can see that, you know, all the way to the right is fine, all the way to the left, and the same thing with looking straight, all fine. But when we have a deficit that's affecting our right eye, so these gaze palsies that I was just referring to that can happen in the brainstem, here's a cranial nerve 3 palsy, a cranial nerve 4 palsy, and a 6 palsy. So we've got different deviations that we can see when we're affecting the cranial nerve 3, 4, and 6. So 3 is going to give us a lateral deviation, a downward deviation, and it could also give us a ptosis. So you can see that even when this person's looking straight, they've got an eye that's going down and out. And that stays down and out the whole time, even when they look right, even when they look left. Okay, so that's affecting all of these muscles here in this eye, and it's giving that palsy. So a third cranial nerve palsy. A 4 is giving us an upward deviation, which is really noticeable when this person looks straight at us. We can see that their eye is tipped up a little bit. And again, when they look, especially to the left, we can see it really tipped up. Not as noticeable here, perhaps, but really when they look left, we can see that that right eye is tipped up. And then cranial nerve 6 palsy is the medial deviation. So we can see it's kind of tipped in, kind of like cross-eyed almost, looking in towards the nose. Not as noticeable when they look left, maybe, but very noticeable when they look right. So also tipped in towards the nose a little bit. A cranial nerve 4 and a 6 palsy are not going to be as common, but a cranial nerve 3 palsy is going to be a lot more common. So again, that's the eye that's deviating laterally and down. The pupil exam, if you have dilated or non-reactive pupils, that's really more points towards a space occupying lesion like a brain tumor or something like that. But if the pupil is spared, then it points more towards an ischemic etiology. You could also have loss of accommodation. So right when the patient, when you do going towards your nose, like look at my finger, and you could also have a ptosis as well. And a third cranial nerve palsy is going to localize us to a basilar artery thrombosis, or could be a symptom of someone who has a subarachnoid hemorrhage who has a PCOM-A aneurysm that has ruptured. So we always would need to look at our vascular imaging for this particular more rare finding, but make sure that, you know, the patient doesn't have a subarachnoid hemorrhage and really looked at that basilar artery as well. This picture is very, very thorough and wonderful for trying to understand the different visual field deficits. So before we were talking about more palsies, right? What the eye movements were doing. So the eye movements were deviated or the eye was down and out. This is now looking more at what visual field deficits or vision loss you're going to experience. So a different piece of the assessment. And sometimes I think people get these two confused, right? So eye movements are one thing, but then vision is completely different item to review and to assess. So this picture shows us, here's our eyes up here. So we've got our retinas, and then we've got optic nerves that go down from each eye and they cross at the optic chiasm. So right here's the optic chiasm where there's that crossing. Then we've got the optic tracts that follow back. Then we've got lateral genucleate nucleus that wraps all the way down in these two tracts, the optic radiations, and they head back to our primary visual cortex. So right, our PCA is supplying the majority of that primary visual cortex. What's really nice about this picture is it shows you the different lesions across the optic tracts that give you these different visual symptoms. So if we look just at number 1, this is happening with a lesion happening up here. So before the chiasm usually gives you a one-eyed problem. After the chiasm gives you a two-eyed problem. And that's because if we look at these tracks and we follow this red, right? If we follow the red on this side, it goes up, it crosses, one goes this way and one goes that way. So it supplies this side of that eye and this side of that eye. Same thing with the other side, right? So we're giving input to both eyes when we come from the back of the brain. And so that's an important thing to differentiate too, is it pre-chiasmal, before the chiasm is going to give you a one-eyed thing. After the chiasm is going to give you a two-eyed problem. Right at the chiasm gives you this deficit as well. So number 3, right there could give you a deficit of just one side of the eye. A number 2 could give you, so we got 2 different deficits. Sorry, let me back up. So 1 is going to give you one-eyed vision loss right up here. 2, right in the middle of the optic chiasm, could give you temporal loss. So this is not stroke either, right? This is more like a pituitary tumor perhaps, that's pushing onto that middle of that optic chiasm and giving you vision loss on the outsides. A number 3 is right there on the side of where the optic nerve goes down and the optic chiasm crosses. That could also give you a one-eyed issue. But after the chiasm is going to give you two-eyed problems. So we've got a left homonymous hemianopia over here. And let me just advance this a little bit. So we've got a lesion that would affect number 4. So this spot here or here or here is going to give us a whole side that's missing, right? It's going to affect, it affects the entire optic radiation or the Myers loop, and it can cause an opposite-sided homonymous hemianopia or vision loss on the whole half, the upper and the lower quadrants of both eyes. And then a number 5, which is down here on the optic radiation. That's a lesion that's going to affect our parietal lobe and can interrupt the lower optic radiation or of the Myers loop and cause a contralateral, so opposite side, inferior quadrantinopia, which is a pie on the floor, so vision loss in the lower quadrant. So the lower loop gives us a lower quadrant that's missing, and the upper gives us an upper quadrant that's missing. So this could be number 6, so that upper loop, a lesion of the temporal lobe that can interrupt the lower optic radiation of the Myers loop and cause a contralateral superior quadrantinopia or pie in the sky, so a piece that's missing from the top portion. And then number 7 is also back here as well and affects both, and therefore you get a whole half that's missing as well. So this is typically what we see, right? A number 7 vision loss can be seen when we have affected our PCAs and we've maybe occluded an entire PCA artery. But you can also see, remember that our MCA takes up about this much of a wedge. So we can see vision issues as well with MCA strokes too. We tend to think of PCA as the only spot that can give us visual field deficits, but MCA strokes can do the same thing because it's pressing on these optic radiations or optic loops and can give us some of these visual deficits as well. I couldn't help but throw in a little thing on Brayo and Crayo. So our central retinal artery occlusions and our branch retinal artery occlusions. So this is a diagram of the back of the eye. So really these are strokes of the eye. And we've got our central retinal artery going through here to feed the back of the eye. Typically what we'll see with these types of patients is a sudden and painless loss of vision in one eye. Some talk about an experience of amaurosis fugak, which is a temporary loss and sometimes referred to as like a curtain going down. And really, this is definitively diagnosed with an ophthalmologist looking to find a cherry red spot on a fundoscopy. So really, and obviously could be a branch retinal artery occlusion as well. So a branch that's coming off of the central retinal artery. But still a very important population for us to be thinking about and looking at. And I know that there's going to be a whole webinar dedicated in 2026 to Creo and Braille population. So I'm not going to spend too much time talking about that here. I did also want to add in a little note about diplopia, and remembering that diplopia is almost always caused by lesions affecting the ocular motor system in the brainstem, so cranials 3, 4, and 6, and is not the occipital lobe. It usually occurs most frequently with lesions of the extraocular eye movements and muscles, or the ocular motor nerves, but remember that it's more brainstem focused, it's more cranial nerve focused, it's not occipital lobe or PCA that we usually see diplopia from. All right, I will wrap up there and I will take any questions that you have.
There was a question about if they could get a copy of the presentation in PowerPoint form.
Sure.
And that was from Shannon Warner.
Yeah, I'm happy to send that around. I am very willing to share anything. I feel like we don't need to reinvent the wheel. So I'm happy to share and have you take it and use however you would like. Absolutely.
And there was, can you share it with all of us?
And what? Share with everybody? Sure. Sure. No problem.
Yeah, it was a lot of information. I'm sure it's tough to come up with questions that are appropriate. Was well covered.
Very good. I'm actually surprised I did that in record time, and I hope I didn't talk too fast, but.
No, I thought it went well. I thought it was very good.
Very good.
And it was a lot of information, and I don't think you dummied it down like totally. I think it was at a good level.
Very good.
Doesn't look like there's any question.
Okay.
Oh, wait, hold on. Let me try this. Oh, okay, hold on. Could you please say the other pie in the sky and what the other one was?
Sure, let me back up a little bit. So pie on the floor is a number 5 lesion, so giving you this bottom quadrant. So that's a lesion of the parietal lobe that can affect the lower optic radiation of the Meyer's loop and cause an opposite side inferior quadrantinopia. So a mouthful. And then the number 6 is the one with the pie in the sky. So lesions of the temporal lobe interrupt the lower optic radiation in Meyer's loop. So same loop, but just a different one. And cause that pie in the sky. And this is getting into the weeds a little bit, right? Like this is definitely a more advanced part. So just take that with a grain of salt. I think that the eye functions are definitely a more advanced level of clinical localization and a little bit harder to tease out. But interesting, right? I think it's something that all of us could use additional knowledge on, and is always a little bit challenging when you're dealing with eye components.
There was a question. What is your recommendation on how to teach and approach with new nurses?
Oh, great question. So I think that, most of our teaching to new nurses or to just stroke nurses in general is surrounds the NIH stroke scale when we have to teach the NIH stroke scale. So I like to teach clinical localization at the same time that I teach the NIH stroke scale. So I like to combine the two together because I think it's important for nurses, especially new ones, to understand the why behind things. So I try to connect what you're assessing on the NIH stroke scale with what the clinical localization of that particular item would be. And then I spend some time talking about all the things that the NIH stroke scale doesn't cover, right? To make sure that we are doing a complete neurologic assessment on patients. But I think that that's the best way to try to teach clinical localization, is to try to tie it with the NIH stroke scale, because that's such a common thing that we're all teaching nurses. So.
There was a couple questions, Alicia, about the NIH. Can you send your materials for teaching NIH stroke scale, or do you have slides on how you teach that?
I don't have, well, actually, though, I do have slides on how I teach that because we use, at my facility, we use the NIH from Stryker that was built several years ago. I'm in the videos for the Stryker NIH stroke scale videos, and they're built into 3 PowerPoint modules. I can share those if people would like those. And in the notes are what I say when I teach that class, because we have multiple people teaching that class now across our health system. And so those notes are in there. So it would have how I teach typically in the notes section. So yeah, I'm happy to send that around as well.
Yes, they had asked for an updated version, but yes,
Yeah, we do need to get an updated version of that because it is based off of the old cards and has some outdated pieces in it, but I'll send what I have, and hopefully that's helpful.
They said maybe you should have a webinar on that.
That's a good idea. Very good idea. I will tell you that this presentation was very similar, but at a little bit lower of a level for all of our on-demand education that is coming through ANVC very soon. We are working on launching the Advanced Stroke Coordinator and the CNIC, the Certified Neurovascular Interventional Clinician review courses, and then our ANVP and our NVRN will follow those. But this is what we consider a core curriculum class for all of those courses. So the clinical localization is obviously more in depth than this for those courses, but this kind of gave you a little sneak peek essentially at what's included in that on-demand education. So if you're interested in any of the review courses, they will all have a component of the clinical localization in there as well. There's also clinical localization cards that are available on ANVC's website that come in a bundle of 25. And those are nice little pocket cards that kind of outline the different deficits that you'd see with each vessel. And those can be really helpful for stroke nurses as well. I know that lots of people have bought them as like a Christmas gift or things like that, so that people have a quick pocket reference guide of the different deficits that you can see. So that can be something to take advantage of as well.
Let's see. I think you made everybody's day.
Perfect.
I don't see any more questions. I think you covered it. That's lots of information and lots of helpful teaching tools.
Awesome. I'm glad. Thanks, everybody. Have a good rest of your day.